Yeah, I wanted to ask, what's the typical tumor size for you to do the embolization, either radiological or the chemo?
Can you hear me? Okay. For the embolization in the liver, there wouldn't be a size that will prevent me from doing the procedure, unless I would say, even when we say in our doctor's meeting that there's so much tumor in the liver that the patient may not respond well for our procedure. What we have developed in our with our team at UK is that we will, as I mentioned before, that I would do the right side or the left side. What we have enough experience in right now, even doing it in more stage approach. If we think that there's so much that we should not even do the procedure, we have developed enough expertise that we will cut the liver without cutting it in 4 procedures, and we'll do one at a time. We'll do like half of the right side and then the other half of the right side. And the first procedure is the one where I will get a feel of how the patient will do. So I know in some places they will say, no, there's too much in the liver for you to do something, but we have work around that where we would do a little bit of the liver here, see how the patient responds, and then do another one. And there are patients that had 4 procedures just to complete the whole liver embolization. So.
Hi, I'm Bonnie, and I want to know, can PRRT cause bone loss?
Can you hear me? Okay, so PRT in terms of bone loss, I am not aware of that. And so with the, I would definitely look for other causes of bone loss. That could be related to other treatments that are being given.
Are there any studies showing that lenriotide should be used for more than 14 months after PRRT?
So it's it's an interesting question. So really, a lot of this it's somewhat of a controversial area as far as what do you do with a patient who's on a somatostatin analog and they start progressing. There's a school of thought that says we're gonna discontinue the somatostatin analog because you progressed on it and change it to something different. There's another school of thought that says we're going to continue the somatostatin analog because you will progress slower than if we don't continue, but we're going to add something to it. So, some of it, has to do with some of the prior trial designs. I will tell you, in oncology, it is rare that when a patient progresses, we continue the same treatment. It's not working for you. So why would I continue it? With the SSAs, in my practice, unless patients are symptomatic from a hormonal syndrome, and I need the SSA to control that, if someone progresses on it, I stop it. Now what do we do with the PRRT? So the NETTER-1 study continued this, and I will tell you, for many of my, so to answer your question is no, that's a long-winded answer to a short question, but I think it's a conversation with your doc as far as what are the benefits of continuing this after PRRT. I think I don't continue it. Usually, I'm not sure about you. What is your practice?
So pretty much what we just heard from Rob. So I would continue it if I need to control the syndrome, let's say the diarrhea and things like that. And beyond the PRT, we just this is a study that needs to be done. This is actually one of those studies that I sometimes say is like really not scientifically interesting, but could really be important for patients. So I'm not sure we're ever going to get this done.
Dave Vickery, United Press International. No, I'm sorry. I mean, I'm from Michigan. I get confused. Several times we've heard the word immunotherapy and that it generally isn't effective. Can you give me an example of what immunotherapy would be? What are those treatments? Because I'm not clicking with a definition of immunotherapy.
So I can try. So the way I look at immunotherapy is that we're really using your own or training your own immune system to recognize cancer cells. So all of us have our immune system always on, but yet people are getting cancer and your immune system is not seeing the cancer. So what we're trying to do is really just to kickstart it or rev it up with therapy. So your immune system has these natural brakes. So if there were no brakes on the immune system, it would just go bonkers and attack pretty much everything in your own body. And there are these natural brakes on it. So these drugs, these immunotherapy drugs, they actually lift the brakes off the immune system. So now you have a sort of more aggressive immune system that is starting to see cancer cells it didn't see before. So that's sort of the way I think about it. And then that may come at a cost, so it doesn't work for all tumors, and sometimes you just lift the brakes too much and all of a sudden you have autoimmune diseases because now your new and revved up immune system is actually starting to attack normal parts of your body. We have to stop the immunotherapy, put someone on steroids, try to calm things down, and occasionally we can actually start back on immunotherapy. So essentially, we're just kick-starting your own immune system. So you probably do more immunotherapy than I do.
Yeah, I guess my my other hat in my professional life is I see patients with not just lung neuroendocrine tumors, but all of lung cancers. So I use a ton of immunotherapy, and it's clearly been a game changer for many cancers, including lung cancer. And the way I describe it is cancers hide from the immune system, and in a lot of our drugs, they go and attack the cancer. These drugs don't necessarily attack the cancer, they allow the immune system to see the cancer, and allow the immune system to do its job. Again, so these are drugs that you may have heard of. There's a lot of commercials on TV for nivolumab or Opdivo or pembrolizumab, which is Keytruda. So these, when you see these commercials, that's what they're talking about, the immune therapy. They're excellent, normally very well tolerated, but you can run into your share of side effects. In the neuroendocrine space, the studies just have not really been done that have showed a whole lot of benefit. There's some smaller data, especially in the lung, that shows that combination immunotherapy may be beneficial. I use it in my patients when I get to that point where I've exhausted other options, but it's something that, it's imperfect. I think, as Dr. Alf Danderson had pointed out, the future is going to be combining this with other agents, and we're getting better. This is still a relatively new class of therapy.
Such a huge game changer for neuroendocrine cancers, partly because these neuroendocrine tumors are supposed to be, we call them cold tumors. They're not very immunogenic, so they don't really elicit that sort of immune response that we see in melanomas, bladder cancers and non-small cell lung cancers. So the next generation of immunotherapy-based studies are looking into making these supposedly cold tumors hot. How can we make these low-grade, well-defined neuroendocrine tumors more immunogenic, so they can then synergize with immunotherapy? Because the real advantage of immunotherapy is long-term durable responses with less side effects or traditional chemotherapy side effects, right? So these immunotherapies can, if they work really well. So what would be some of these combinations? Here at Markey Cancer Center, we are developing a trial, and it's going to be a national multi-center study where we are going to be using some oncolytic viruses which specifically target neuroendocrine tumors. We'll be writing a paper very soon coming out, kind of laying down the hypothesis and the preclinical data behind it. But very soon we will have the real first-in-human kind of clinical trial, multi-center trial, and hopefully our partners here would also join us in making that trial a success. So there are exciting things coming in that front as well. So just wanted to give a plug for that study. Thank you.
Okay, you're next. I'm trying to be fair.
Hi, Katie Davis from Kentucky. And I have a question regarding repeating a therapy such as CAPTEM. I took CAPTEM for about a year and had great success, but then it was stopped due to the risk of side effects. I've since had PRRT. How often would you or do you revisit CAPTEM as it was a successful therapy and not terminated due to progression?
Yeah, so that's an excellent question. So can certainly cause some, the fear is that it can long-term bone marrow toxicities, and so nobody really knows the duration of how long somebody is supposed to be on this. Some investigators will say, all right, 6 months, or I stop it after 6 months, or I stop it after a year, 2 years. I've had patients on it longer than that, but that is the concern of that bone marrow toxicity, and I've certainly seen it. This long-term, including leukemias. So it's something that I guess in the NET world, we use this, occasionally. I mean, quite a bit, but in the brain tumor world, they use this all the time, and so that's that's one of their go-to drugs. So really, that toxicity data is coming more from that, and then the duration of how long to go. What I normally do is I'll keep people on it, usually for about a year, if they're responding to it and doing well and tolerating it, and then I give people a break. And most of the time, there are a lot of times that I can continue to have that response. So that meaning the tumor's not growing. There's the other therapies. You mentioned the Prrt, which is, also can be damaging to the bone marrow as well. So does this, is there overlapping toxicities that we need to worry about? Certainly, if I take a patient off of a therapy because of patient preference or my fear of eventual toxicities, but that therapy was working, there's no reason I can't go back to that therapy and still think about getting a response.
Well, I don't think I have much to what Ramirez said. So I used to treat with CAPTEM for like 2, even 3 years when this first came out, but now we're actually stopping after 9 to 12 months, assuming there is a response. And this really strange is happening that sometimes the tumors can continue to shrink. I'm fading in and out here. So seems like sometimes even after stopping the CAPTEM after a 9 to 12 months can be ongoing shrinkage, even months after the drug is gone from your system. This is something we're not really understanding well, but I have one patient who had an excellent response to CAPTEM, and even 2 years after stopping, he is still showing response in the liver. And so there's a big cancer hospital you may have heard of in New York, Memorial Sloan Kettering. They actually are actively looking at this now. So trying to find out who are these people who have these what they call exceptional response.
I was just wondering what you meant by extra pancreatic.
Yeah, so extra pancreatic essentially is something that happens outside of the pancreas. That's the way, extra pancreatic. So neuron tumors outside of the pancreas.
Okay, my question deals with the liver embolization therapy. So what I wondered is, could you address the risk of abscess following that therapy, and also does fatty liver preclude possibly having that therapy, and how is it determined which one of the embolization therapies is used, whether it's bland, chemo, or radio? Okay,
I'll start from the last question. We don't have any data that supports one embolization better than the other. I would say patients, wherever that center that you're going to, whatever their experience is with, let them do it. So if they have experience with chemoembolization, chemoembolization will do the job. At our institution, we do bland embolization. We don't put any chemo on the beads. We know that what kills those tumors is just cutting the blood supply is enough to kill those tumors. There's no need to add that chemotherapy on top of the beads. So whatever, and it's every center, you go somewhere else, you ask somebody else, they will tell you, oh, what we do is chemoembolization is the best thing. And I would say, if that's what their experience is, yeah, that's fine. That's the best thing then. Because the response is the same, like the in the liver, regardless of which modality you used. The second question, fatty liver, it depends on how the liver is, how advanced is that fatty liver. And also it depends on what we call tumor burden, how much tumor is in the liver. So it's a combination of factors in addition to how the patient is doing. So we assess the patient, the risk. But in general, fatty liver will not stop us from doing it because liver cancer itself that originated from the liver, those patients have not only fatty liver, but they have liver cirrhosis. So it's even the worst stage of that liver disease, and we still do the embolization on them. So a little bit of fatty liver here and there is not going to stop us. And the first question in terms of abscess risk with this, we give patients antibiotics, and if the patient did not have a Whipple procedure or a drain through the biliary tree, through the bile ducts, because any manipulation of the biliary tree through the bile ducts will increase the risk of developing a liver abscess, then the risk is going to be 2 to 3%, and with the antibiotics, it's probably going to be less. We've had patients that we did the embolization on, and afterwards the tumor died, and they had abdominal pain or they had something. They went and got a scan, and then when they look at the scan, they're like, "Oh, you have a liver abscess." We know it's not liver abscess. It's that tumor. It is dead. It's shrunken. It's that dead tissue, but it is not infected tissue. Sometimes there might be a superimposed infection, but we tell our patients, if you go somewhere and they tell you need a drain, just wait, get the antibiotics, talk to us, and then we'll let you know if you need a drain or not.
Okay, very good. We have time for one more question.
Hi, I'm Gigi Baker, and I'm from Lexington. And I wanted to ask, why do you disqualify somebody from the local radiotherapy from people who have had their liver resectioned? What's like, is it because of the blood supply has been compromised?
If patient had liver resection, it depends on what they have done. I mean, is it a small part of their liver or is it a big part of their liver? And even if they had liver resection, the remaining liver might have grown to be able to handle an embolization. It is not a solid exclusion criteria. If somebody tells me that they had a liver resection, it doesn't mean they're not candidates. No, they are still candidates, and they can undergo chemoembolization, radioembolization, or bland embolization. Other factors, and depends what's the status of the remaining liver, what are the liver enzymes, how is the patient doing overall. But the short answer is they're not excluded. No, they are still part of the treatment, for those treatment modalities.
Follow-up question on that. What about post-resection, let's suppose post-Whipple surgery, post-primary tumor resection? What modalities of local regional therapies can we pursue, or is it contraindication?
We've had patients that had Whipple resection, and they came to us for radioembolization or bland or chemoembolization. They will get a longer antibiotic regimen. So tell the patient to start antibiotics before the procedure, like a week, 10 days before the procedure, and stay on the antibiotic for 3 weeks post-procedure, hoping that they don't develop a liver abscess. The reason is because of the Whipple is not worrying about the liver, but worrying about the new connection that the surgeon has created. It will facilitate the bacteria to go from the intestine back into the liver and cause the infection. So it is not contraindicated, but we just give the patients a little bit more antibiotic to prevent an infection in the liver. And we prefer on those patients radioembolization with radiation rather than chemo or bland embolization. And the reason is the particles that we use for the radioembolization, they are smaller than the ones for chemoembolization and or bland embolization. And with bland embolization, you have a tube, you cut the blood supply, you cut it, nothing gonna go through it. While with the radioembolization, because they are smaller and because we're relying on the radiation to work, we're not necessarily cutting the blood supply. We're just letting the radiation go, sit there and do their job. So the blood supply is not really cut or stopped. That will minimize the risk of infection, because how do we prevent an infection? By our body, by letting the blood circulate and get there and stop the infection. If you cut the blood supply, this is where the infection occurs.
Wonderful. I agree with you. And we have to remember, at the end of the day, it's none of these therapies, barring surgery for local or early stage disease, is curative in nature. So we have to see the risk, benefits, and trade-offs. So for example, somebody after a big Whipple's, which is a surgery for pancreatic cancer, pancreatic neuroendocrine tumor, or like the part of the head of pancreas taken out, it can alter the vasculature, the blood supply, in a way where it can put patients at high risk for infections and liver abscesses. So you have to discuss it with the providers and make sure you're the right candidate. So it's, again, risk and benefit. So no hard stops, but have to reevaluate that finally. Wonderful. That was a good panel discussion. Thank you so much for having, for being here and answering a question. Now to the best part of the day.